Recording. Okay, good morning, everybody. It's really a nice opportunity to present to you Sarah Walters. She's going to talk about cystic fibrosis. So Sarah Walters is an HPCSA registered genetic counselor and a medical scientist. She currently holds the position of principal genetic counselor at Ampath. She has over 20 years of experience in counseling clients with various genetic conditions, from prenatal to postnatal to late onset disorders and cancer, among others. She is also involved in lab work analysis and sequencing and genetic arrays. She has particular interest in educating other healthcare professionals in human genetics and the intricacies of genetic testing and their applications. She brings teaching and mentoring expertise from instructing medical students at the University of Witwatersrand. She is also currently training and coordinating for intern medical scientists in genetics at the NRL Genetics Laboratory. She also serves as an assessor, moderator, and site assessor for the HPCSA. She has also presented at many local and international conferences. She has worked extensively in both state and private with children, adults, and families with cystic fibrosis. And currently, she is finalising a PhD. Thank you so much, Sarah, for presenting. We're looking forward to your presentation.
I'm excited.
Thank you and good morning to everyone. Hope you're all doing well. I decided to touch on and just recap cystic fibrosis genetics, just in case there's some dusty minds out there, and then also to look at the traditional treatment and then what the new treatments are all about. So just a recap of genetic cystic fibrosis in itself. There are many systems that cystic fibrosis can affect. The respiratory system, where there are recurrent lung infections, there can be nasal polyps, sinusitis. The gastrointestinal system, where pancreatic insufficiency is really common. General failure to thrive of babies, and at birth, meconium ileus is one of the signature signs. In the endocrine and metabolic systems, diabetes related to pancreatic dysfunction, and increased risk for osteoporosis due to vitamin D deficiency. In the hepatobiliary system, we have liver disease, fatty livers, and gallstones. And then in the reproductive system is male infertility caused by congenital bilateral absence of the vas deferens. It was always thought that females are less fertile, but in my experience, that is not true. When I was working at the Joburg Glen, we had a young girl who phoned in and said that she thinks that she might be a little bit pregnant. So it was a surprise for her and for everyone else, because we thought that the mucus in the uterus would be too thick and sticky to be able to conceive. But we've had many adult females with cystic fibrosis who've had children now. And I was also involved in the first naturally conceived twins, not doing it myself, but discovering it on ultrasound. First naturally conceived twins in a woman with cystic fibrosis. So that was such an exciting day for us all. Arrows are not working, so let's do this. There we go. So just as a reminder, the cystic fibrosis gene is called the cystic fibrosis transmembrane regulator gene, shortened to CFTR. It's located on chromosome 7 in the long arm at 7q31.2. The whole gene is 190 kilobases long, and it's quite a large gene, so it has 27 exons. And if you remember anything about proteins and how they're made, that means that 27 exons is still quite a big gene. Not the biggest that we have, but quite large. Then looking at several databases, over 1,500 pathogenic variants have been described. Some say over 2,000 already. but they in ClinVar, which is one of the international databases we use, there are 5,435 variants that have been described. But now not all of those variants are pathogenic. So I'll show you just in a minute, but all the different variants, so we don't use the word mutations anymore. We use the terms pathogenic or likely pathogenic variants. We use the terms benign or likely benign variants. And then we use the term where we aren't or nobody is able to classify for sure because there's insufficient evidence. We use the middle category of the variants of uncertain clinical significance. So the carrier frequency in the Caucasian population worldwide is around about 1 in 25 to 1 in 30. In different populations, we have different carrier frequencies. So in our South African Black population, we have the carrier frequencies around about 1 in 50 or so. So what does the protein do that is made by the CFTR gene? So it encodes a protein that regulates, it sits in the cell membrane and regulates the chloride and the bicarbonate ion transport across epithelial cells. So the easiest way that I remember how the protein works is that it's like a gate, and either the gate is open that will allow these elements to cross over, or the gate is closed, which doesn't. And the purpose of this gate opening and closing is to maintain hydration and mucus clearance in lungs and the other organs. So you know that cystic fibrosis, as I've said already, affects many types of organs. So obviously the epithelial cells in the gastrointestinal tract, in the lungs, in the reproductive system, all of those are affected by a faulty protein function. So here's the dusting off the cobwebs of autosomal recessive inheritance. Can they see my pointer? No. Let me just see. Here we go. There's a pointer. There we go. Right. So the traditional autosomal recessive inheritance is that both mom and dad are carriers. So that means that they have one CFTR gene that is not functional, that has a change in it, and one CFTR gene that is working enough, so basically working at 50% in total across the body, but it seems to be enough that the carrier parent does not have any effects of cystic fibrosis. However, some latest research shows that carrier parents could have milder effects like asthma, recurrent bronchitis, and other airway problems. So 2 carrier parents are at risk, 1 in 4 risk of having an infected child. So this is the Punnett square that you probably did in, I don't know, second year varsity, where the capital A is the normal functioning gene and the small a is the faulty gene. So with every pregnancy, 2 carrier parents are at risk of having an affected child, a 50% risk of having a child who is a carrier, just like the parents, and a 25% risk of having a child who is not affected by cystic fibrosis at all. This next diagram here we put here because of carrier status and checking carrier status. So when there is a family history of cystic fibrosis in the family, we often check the siblings to see if they are carriers. And then as they grow up and decide that they want to have children, it's really important that their partner be tested. So I'll talk in a second about carrier testing, but it's really important to sequence the whole gene and not limit it to only a certain number of cystic fibrosis variants, because you want to detect any and all cystic fibrosis pathogenic variants in the unaffected parent. So if the unaffected parent turns out to not be a carrier, then the risk for this couple would be 50% of having a carrier child, just like the mother or father, whichever one it is, and then a 50% chance of having a child who is not a carrier and also not affected. So coming to sequencing and what happens from the lab side. So There are two types of sequencing: Sanger sequencing, which is our traditional type of sequencing that was in prenatal started being done in the 70s, and then NGS, which is our massively parallel sequencing. So there are pros and cons to both. And for such a big gene as cystic fibrosis, we choose to do it by NGS. This is just a picture of what it would look like on the computer when we print out a sequence. And what we have to do is compare that sequence against what we call a reference sequence. So a reference sequence is an international baseline or reference sequence that is made up of a few people's DNA. And so our patient's DNA is compared with that reference sequence. And any and all changes that are found in the patient's DNA need to be classified. And as I said, either into likely pathogenic, benign, or the variants of uncertain significance. So I thought I'd just include, I think the writing is a little bit small, just to explain to you how we describe variants and how the results should be read. So reading a sequence variant is very similar to finding a street address in a house, in a suburb, in a town, in a country. So the first thing that the way in which we describe the gene is by, first of all, putting the gene name, then the copy DNA code, and then after that comes the protein code. So if we have a look at this example, this is CFTR, which is the gene that we've looked at. The 3272 minus 26A to G is the copy DNA sequence. So what this means is that 3272 is at the beginning of an exon. And if we're going minus, we're going backwards into the intron, and 26 bases into the intron, there's an A to G change or missense mutation. And what this means is that there is no protein that's been made from this. And this is called a splice site variant because it's got to do with the splice sites of the exon and the intron when the messenger RNA is processed. Here's another example, CFTR 163C1632, G to T. And what that causes in the protein is instead of the amino acid G being there at position 542, the change from a G to a T introduces a premature stop codon. So the X on the end of any protein code means that this is a premature stop codon. Therefore, your DNA will stop, your messenger RNA will not be processed further than that because it's been told to stop very early on in the DNA sequence. And then the last example I've got here is CFTR 3909, where a C is substituted by a G, and this causes the N1303K pathogenic variant, and this is called a missense variant. So all three of these are typical cystic fibrosis types of pathogenic variants. So how we classify them, like I said, is into pathogenic, likely benign, and then this middle category of variants of uncertain significance. So the ACMG, the American College of Medical Genetics, has worked out a classification system which everybody in the world uses in order to classify a variant. So I've just put this table in to show you how many steps we have to go through when considering whether a sequence variant is pathogenic or not. So we look at population data, we look at computational and predictive data, we look at functional data, segregation data, so that's if we need to test appearance as well. We look at de novo data, so when there's something different that has never been described before. We look at the allelic data, and then we look through various databases in order to see if the variant has been described before, how other people have described the variant, and whether we can just classify that variant in the same manner. So a variant of uncertain significance is a variant whose impact on the disease is unclear because we don't have enough worldwide evidence. And so it could be reclassified in the future. but its significance remains undetermined until such time that there is sufficient evidence to be able to classify it as benign or pathogenic. So when we send certain tests overseas, what we found is that the other day I received a report back that I'd sent across in 2022, and one of the variants of uncertain significance had been reclassified. So the company that did the sequencing for us then reclassified it because of extra information that they managed to come across. So the main point about a variant of uncertain significance is that no clinical management decision should be made on the basis of a VUS. So if you've got one pathogenic variant and one VUS in an autosomal recessive disease, you cannot say that that person is affected, or it confirms the diagnosis. So the different types of variants that we come across are the nonsense variants, which introduce a premature stop codon. So it leads to a truncated protein, and the variant either ends with an X or it ends with a star. Missense variants are what we call substitution variants, where one base has been substituted for another. Indels, you can have frame shift indels and you can have in-frame indels. And this is where there's insertion or deletion of nucleotides that shift the reading frame or don't shift the reading frame. So it all depends on what the base changes are with the in-frame deletion, because the rest of the protein, then the amino acid sequence won't change. But with the frame shift change, the amino acid sequence will change. And then sometimes we have silent or synonymous variants. And sometimes these are pathogenic and sometimes they aren't, they're benign. So it all depends on what the effect is on the protein. The types of cystic fibrosis genetic testing that exist in the country at the moment is that there's targeted analysis where the particular laboratory will use a specific kit. So we used to use a 30 mutation kit. I can say mutation because that's what they were called then. And now most of the labs that I'm aware of use 50 pathogenic variant kit. So that means that they look at 50 of the most common pathogenic variants that are known in the population group at that time. So it all depends on where the kit is manufactured, because if it's the French manufactured kit, then it's going to be the most common variants in France. Or if it's produced in the United States, then it will be the 50 most common variants, pathogenic variants in their population. So the problem is that we don't have a good idea of what all of the pathogenic variants are in South Africa at this point in time. So when doing testing, we know that only 50 of the currently known pathogenic variants are tested. And so when you've got 1,500 to 2,000 variants that we know are pathogenic or likely pathogenic, if we're only looking at 50, we're missing a whole lot. And traditionally, or because of history, we know that many people in our general population have not been sequenced at all. So Ampath offers full cystic fibrosis sequencing of all 27 exons. And what we found as well, we look at copy number variation. So that basically is looking to see, are there 2 copies of every exon present in the patient? So any and all variants should be detected by sequencing and copy number variation. And what we found, as part of my PhD, is what we found is that in the Black population is that there are many copy number variants that have been detected. So it's going to be really important going forward to make sure that copy number variations are checked. All right, so pathogenic variants and the era of new treatments has come about because the approval of CFTR targeted therapeutics. So these are called modulators, and what they do, what the aim of them is to rescue the underlying defect. It doesn't take it away, but it tries to rescue it. So up to about 90% of individuals who have a delta F508 pathogenic variant could be treated with one of the new modulator therapies. And I think the reason that everyone is concentrated on the delta F508 variant in terms of the modulators is that worldwide, this is the most common pathogenic variant that causes cystic fibrosis. So treatment in areas or in countries where delta F508 is not that common means that they may not be eligible for these new therapies or these new modulator drugs. And so I think it's really important to remember that the modulators don't rescue or change the cystic fibrosis pathogenic change. And certainly it doesn't change the protein function back to normal wild type levels, but it does rescue it to a certain extent. And to a certain extent that actually some of our patients have come off some of their medications because they don't need it anymore. When we're looking at specific types of pathogenic variants, the protein, the pathogenic variant and the protein function are classified into 7 categories. When I first started doing genetics, there were only 4 categories. So it is definitely expanded over time. So if we have a look here, this is what we call our protein. This is our gate where the salts can cross over. And so that is a normal function or normal functioning CFTR protein. So class 1 has been associated with all of our stop codon, premature stop codon pathogenic changes. And so what the modulator drugs do is that they read through that premature stop codon. So remember that the stop codon is 3 bases, and the modulators then read through. And in fact, cystic fibrosis was only the second genetic condition that read-through modulator therapies were designed for. The first one was Duchenne muscular dystrophy, where they had lots of stop codon mutations. The trafficking defects means that the protein does not get to the cell wall as is required. If there's defective regulation, it means that the gate doesn't open and close as it's supposed to. And then class 4 is where there's decreased conductance through the gateway. Class 5 is that there's a reduced amount of protein that is made. And this is one of the common splice site pathogenic variants that we find in our Afrikaner or Caucasian population. Class 6 is that there's an increased turnover and therefore more protein needs to be made in order to sort of normalize it. And then class 7 is one of the newer classes where there is no messenger RNA that is made at all. So therefore, no messenger RNA means no protein. And so the modulator drugs have been designed to work with whichever type of pathogenic variants that we're finding. So traditional cystic fibrosis treatment is concerned with airway clearance, mucolytics, antibiotics, pancreatic enzyme therapy, vitamins, calcium, anything extra, omega-3s that the affected patient is requiring. And traditionally, especially in the pediatric setting, in fact in the adult setting as well, is that if patients are not on the modulator drugs, that they are hospitalized for 2 weeks to have intense therapies, drips, just to up their health. They get physio every day just to up their health a little bit better, to improve their lung functions. And then if we move to the advances in treatment, the small molecules which are the modulator drugs, they specifically target the pathogenic variants, and depending on the pathogenic variant depends on which modulator is used. So the idea is to just improve the function of the cystic fibrosis protein and restore chloride and bicarbonate transport across the membranes. What that also does by restoring that transport is improve mucus hydration so that the mucus is not so thick and sticky. and to reduce the disease severity by that being performed. So some of the modulator drugs that we have, you probably recognize some of the names, but the main ingredients are ivacaftor, lumacaftor, tezacaftor, and elexacaftor. And the one that's currently being used in South Africa that we have accessed through Discovery Executive Plan, as far as I'm aware, is Trikafta, which is the 3 drugs. And anyone who has a delta F508 deletion and either another delta F508 deletion or another pathogenic variant that creates minimal function, these are the people that need to go onto the Trikafta. And so my understanding is that Discovery do pay, and that Vertex, the pharmaceutical company that produces Trikafta, has given South Africa a reduced rate. There was a lot of petitioning and class action cases, and then all of a sudden we were given permission to use Trikafta at a reduced rate. So that's been fabulous, and it actually works so well. And you see how much the lung function of our affected patients increases. So there's 3 types of modulators: the potentiators, which target the gating variant. So it increases the chance that the salts will pass through the membrane. There are the correctors that work with the types of pathogenic variants that cause misfolding of the protein. And what they do is that they increase the amount of protein in the cell membrane. So the protein might not be functioning perfectly because it's misfolded, but at least there is more protein in the cell membrane. And then the combination therapy, which uses all 3 of the drugs together, targets delta F, as I said, delta F homozygosity and delta F with another pathogenic variant. So newer therapies which are on the way and are busy in trials, not in humans yet, but in the lab, are gene therapies, where a corrected version of the cystic fibrosis gene in the haploid form, so in a single strand, is introduced into the cell with a vector such as a virus. And that has been going on for quite a while. I remember when they first started thinking about this. So this has been going on for decades. And what the issue is that even if this gene therapy works, you're introducing it into epithelial cells. And what happens with epithelial cells is that they slough off over time. So they're working on trying to get this virus or the introduction of the normalized gene to continue replicating in many layers of the epithelial cells, which I think has been a challenge so far. And then gene editing with CRISPR-Cas9, which was all the hype, is to cut out the part of the sequence that is incorrect and to insert a corrected piece of DNA that then makes your cystic fibrosis gene normal. So that is also still in vitro trials. And yeah, we look forward to seeing what they have to discover. They're nowhere near human trials at this point in time in terms of cystic fibrosis, as far as I'm aware. And it would be remiss of me to exclude genetic counselling. So we see many patients who are affected or with cystic fibrosis. Many people now come with their partners to be tested. And so just in terms of communication and listening and speaking for us in terms of genetic counselling is going to be really important. Speaking because we educate. We do like a mini Genetics 101 on cystic fibrosis and how autosomal recessive works. But we listen to the patients most of the time. That's our main job. We take family histories. We understand how cystic fibrosis has affected them. There is a fabulous cystic fibrosis support group. And so we can refer people to there if we need. And these are our contact details. If anyone has any questions, any queries, any strange questions. We always try and do what we can to assist. We have a clinical team of 1 clinical geneticist, and then we have 3 genetic counsellors. 2 are based in Centurion and 1 is based in Ballito. But we do in-person genetic counselling appointments, and we also do online genetic counselling appointments. So we're able to reach as many people as possible. And this came about obviously during COVID, where we weren't allowed to see people face to face. And so we worked on an online type of counselling session. And I think that sums up what I have to say today.
Thank you so much, Sarah. This is really nice, amazing presentation, but also perhaps really to emphasize the platform to say that we need to bring labs and clinicians together and hear different voices. And today you're really giving us, I think, the different perspective from the laboratory aspect of it, and also for being an expert in genetics. And it's really, for me, it was quite nice, beautiful, well summarized, much more details as compared when you read your Harrison or you read your textbook Fisherman for pulmonology. You know, it's quite so many information, but this is very well packaged. What I want to ask you currently, surprising enough,
not a difficult question.
Surprising enough that we have actually, I think we have the currently diagnosed 3 patients. 1 was 47, 52, and 41.
Yes.
Which previously been treated as asthmatic, and all of them got Delta 509 mutation.
Delta 509?
Yes.
Okay, that's interesting.
Yeah. So now they've been in the obviously, because the conventional teaching that cystic fibrosis can be diagnosed during the childhood, but obviously depends on the mutations and how severe it is. Sometimes those people are missed, because one of them was a child that was actually being seen by a pediatrician and be treated as asthmatic, and she was 13, and the parents come for second opinion, test confirmed cystic fibrosis. Now she's on the prior captor, which is actually discovery does pay, not just executive plan, but all the plans discovery, they will pay up to certain percentage of the funds. Yeah. So my question is that what's your opinion regarding actually why should all these patients be diagnosed so late? Because their lung function are not so bad, you know. I think because when you can't have to look for it. And can you probably elaborate further? What can clinicians out there do to pick up all these problems? Do we need to screen everybody for cystic fibrosis when they have asthma? What's your opinion?
Yeah, that's a difficult one because I'm not a clinician. Can I escape on that?
I'll elaborate on that, yes.
So what I think is that I wouldn't say every patient to be screened for cystic fibrosis. I think you have to look at the diagnostic criteria for cystic fibrosis. If they are failing to thrive, even as a 13-year-old, if they're really skinny, which a lot of 13-year-olds are, if they are having smelly, fatty stools, if they are, do a sweat chloride. Do a sweat chloride as an initial step, because that is still the gold standard for testing for cystic fibrosis. So the sweat chloride test is a good screening tool. 1 positive means that you need to do a second one at a different time. 1 sort of borderline one, I would also recommend that you do another sweat chloride test. And then you can do a fecal elastase test as well. So I think that those 2 are good screening indicators before you jump to the genetics.
Yes, thank you. Yeah, I think what we did always, normally we actually look at a single chloride test because it's quite expensive. And then the same thing as fecal elastase, that take quite a while. So we normally then, because they got asthma, difficult to diagnose, but then that's meet the criteria. They will really force some kind of genetic tests, and obviously looking at other because repeating sometime are not, we find it difficult. You tend to get the same results, and patients become too anxious that they get subjected to the same test again.
Yeah.
But myself and my colleague, Darren, I hope you're on the line. I think for this will be more your questions, more to do with genetics.
Okay.
Most of our patients with the cystic fibrosis, I mean, the most of them, they're extremely intelligent. Is there a relation between cystic fibrosis and IQ? They're very
That I'm
successful,
aware of.
well accomplished. Even my 13-year-old, 14, now she's 15.
Mhm.
She's top of her class.
Awesome.
And all of them, like, they're really well accomplished. So we're thinking cystic fibrosis, if you get it, it's not really a bad thing. It might have advantage in society compared to the rest of the population.
I-
Do you agree?
No, I think that depends on many things. Intelligence is multifactorial. So if CF has got a contribution to that, well, then that's fine. But no, it's so intelligence is so multifactorial that no, I would not directly correlate that. Unless we looked at all of our 500 and odd patients with cystic fibrosis that are on the registry. And do IQ tests on that thing. I don't think that you can claim that even with your 3 patients.
No, I think, look, our thinking was that once you have cystic fibrosis, you kind of have already disadvantage in life.
That's
And
right.
most of the people, I always say human beings, we're always born and we get education. Even through our education, we're supposed to solve problems. From day one, university, you solve problems. When you become a specialist, you solve problems. So now, once you have cystic fibrosis, and most of these people, because they're already 1 foot behind, I think they use that to their advantage. So they're having these medical problems and then probably become a driving factor in their success. Perhaps I think that's what I'd like to
agree
believe.
with that statement. And also, I think that children with cystic fibrosis have a lot to deal with.
Exactly.
And they mature earlier than maybe their peers, because they have to be responsible at school with taking their prions. They have to be responsible for doing their physio every day. So I do think that, as long as the parents are strict and keep them and get them into a proper routine of doing their physio, of doing their nebs, making sure that they take prions with every meal if they have pancreatic insufficiency, then I think that children do mature earlier, and that is probably
And that increases their
a driving force. Why not? Let's just put that hypothesis out there.
Thank you. And guys, any question? Yeah, and I think that Trikafta is the new, I think this young girl was on it.
Mhm.
And she really just, the lung function actually normalized.
Mhm.
And she actually picked up a bit of weight and actually also a bit of height,
Yeah.
which is, I think, for me, is a game changer.
Mhm.
And it's something that actually we should actually probably increase our awareness. The problem that with cystic fibrosis, we diagnose what we know. And the issue that I think you have to screen most asthmatic patients, that are difficult to control, probably have no positive methacholine tests, and please probably you need to do a sweat chloride test. I think currently Ampath probably does them in our setting here. And I think this doesn't have to do a screening test. And if it's positive, again, you could have options repeating it. And obviously, the chloride test is also graded into mild, moderate, and severe. Depends on the how significant is it. And if it's, for me, it's more than 100, 200, I'll go for a complete genetic test. But if it's more than 49, less than 50 or 60, I don't know what's the parameters, you will probably classify that, then perhaps you must repeat it. But always depend on your patients. Some of the patients might not come back. So perhaps I think if you think there's a Caucasian patient, I would probably, because I have experience now, we're having 4 patients that we pick up in the practice. I try to do genetic tests because, again, it's more anxiety to the family, and they wanted to know about that. Genetic tests take about a week or 2. I think
4.
That's a month.
Yes, it is. But there's a lot of work to do when you sequence.
Okay, you hear me, guys? A month test. Okay, don't ask me in 2 weeks. I need my results. It's take a month. You guys.
Okay, that's for the sequencing.
Yeah.
I think that the kit-based testing from other labs does take a shorter time. And so the sequencing does take a long time because it's not the actual lab work, the actual processing of the sample. It's the analysis of looking at each and every single variant and deciding whether they are pathogenic or not. So the actual analysis is what takes the most time.
And then just question out of that, we've seen quite a lot of patients in our practices that also come and they don't really meet diagnosis of asthma, but because they've been like walking around as asthmatic because people just label them as asthmatic. And in fact, that most of them will have probably ciliary dyskinesia or decreased their motility. Is there any kind of genetic test that we could do to confirm, to kind of see, or there's none? How do we assure those patients that because you do a nuclear medicine test, and that thing I always say is really not a specific test, it's if you look at sensitivity and specificity, it's not strong, but those people have mucosal problems because the ciliary as it isn't working properly. How can you help those patients?
So we have a panel of several genes. I can't remember how many genes are on the panel, and it's our primary ciliary dyskinesia panel.
Okay. Oh, good, great. Yeah.
And so we have a panel of that. We've put together a specific panel with the most common genes that cause PCD, and that can be requested, and we can do the sequencing of that. Oh, not off the top of my head, no.
Okay.
I'd have to get back to you with that.
I think maybe if you can share that with me, that would really help a lot, because I think you will have patients that really they can afford and they really want to know what's wrong, and obviously they also want to know for their families. I mean, at the end of the day, knowing is power, because once you know your problems, it's easy to deal with them. So I think maybe it's something that we can speak to the labs and make sure that, Okay, so I think you're going to answer the question. Yes.
Can I just ask a question on the genetics, like CRISPR technology?
Yes.
I read in a news article where that's actually quite evolving technology to literally cut out a faulty section of a gene and replacing it with use of sickle cell disease, diabetes, and some cancers. And you mentioned it here as well. Is it something that is becoming like a more novel approach to correcting genetic abnormalities?
I think it'll become more widespread. We just don't have it here at the moment. So obviously the Western countries are the ones that have all the research money, and they're able to do that kind of testing. And then, obviously trialing it on real humans. But we don't have that kind of technology at the moment available here. So I haven't heard of anyone that's been overseas to have that done. But it definitely is something that's going to be happening in the future.
Guys online, anybody with questions? Anybody awake out there? Yes, Dr. Okoli?
No question from my side. Great presentation. Thanks.
Nothing from my side. Thanks, Sarah.
Thank you. Thanks, guys, for attending. It seems there's no question. Let's enjoy our coffee. And thank you, guys. See you guys next week, Wednesday again, or tomorrow at 7 a.m. again for another great presentation. Thanks, Michelle, for kind introduction and for bringing Sarah to join us. And we really enjoyed it. And I hope you will give us another presentation in the near future.
Oh, yeah.
And it's exciting, especially maybe the other genetic tests.
There's lots of genetic tests.
Yeah, so I thought next time we can also maybe do approach to cystic bronchiectasis, because that's part of the also one of the cystic and non-cystic, to look at the clinical perspective of it one day. Thank you.
Thanks so much, everyone.